A very good evening to everyone. Once again, welcome you all to yet another session of BRENDOS. For those who are new to this forum, BRENDOS is the Breast and Endocrine Society of Western UP, where on a monthly basis, all the clinicians with a special interest in breast and endocrine sciences, we meet together at the end of the month on every last Friday of the month. But this time we are preponing it to the Thursday because of some other commitments. And we discuss in detail about breast and endocrine related real world clinical problems with actual images and the clinical scenarios. So every odd month we discuss about the endocrine cases, every even month we discuss about breast cases. Now March being an odd month, this time we have a very interesting clinical topic which we are going to present today. So but before we present, we come to our actual presentation, there are a few important points. We have different formats, and one of which this time we have done a pre-meet survey, which we are going to present today, the data. And this presentation, this whole discussion is going to be very interesting for sure, because we are not going to discuss the core academics, but the real world problem which the patients with primary hyperparathyroidism actually face. And these challenges are because of the ignorance or lack of awareness among the clinicians. So it is going to be a very tough situations when we discuss about the data. So I hope we all are mature enough to take everything with grace and acceptability. And before I actually start, I would like to introduce, and I'm so glad and delighted, and I can see Arvindan sir also with us. Thank you, sir, for joining. And we are blessed to have you with us. And may I request if all the faculties, they can open their videos so that I can introduce them formally. BRENDOS, every time we try like to integrate all the specialities which help in the management of breast and endocrine related disorders to come together on the same forum, and with clinical problems we try to learn from each other's aspect. And this time we have integrated the API Meerut, the Association of Physicians of India of Meerut, the Meerut branch, and IAES, that is the Indian Association of Endocrine Surgeons, and we have a representative from the Critical Care Society of the Meerut. So now I would like to introduce, because I really want that we have a very good time for discussion. So I'll be keeping the other aspect very crisp and short. I would like to introduce our Dr. Harish Mohan Rastogi sir, HM Rastogi sir. So may I request, sir, if you can switch on your camera so that our participants see you.
Yeah, it is on.
Oh, it's not visible, sir. Dr. HM Rastogi sir is a very senior physician in Meerut, and is currently the secretary of the API Meerut. And thank you, sir, for giving this opportunity that we together can come on the stage and discuss about this clinical problem, which is relevant both for the endocrine surgeons as well as the physicians. So Dr. Abha Gupta ma'am is, I hope she will be joining us shortly. And she is also a very senior physician, and she is currently a professor in Department of Internal Medicine at LLRM Medical College, and she is the president of API Meerut. Dr. Sandeep Jain sir is with us. Thank you, sir, for joining. Sir is a very senior physician of Meerut, and he is the chairman of the Critical Care Society of Meerut. Thank you, sir, for joining once again. Now we have Dr. Gaurav Agrawal, sir. Dr. Gaurav Agrawal, sir, is my mentor, and I learned whatsoever I know about endocrine and breast surgery is because of my mentors, and one of which is Gaurav Agrawal, sir. Thank you, sir. Gaurav Agrawal, sir, has such a huge CV. If I start reading, we can publish a book. So, but in short, if I could say, he is the former head of Department of Breast and Endocrine Surgery at SGPJMS Lucknow, and he is currently the president of Indian Association of Endocrine Surgeons. and he is very renowned figure in the field of breast surgery and endocrine surgery, not only in India but overseas also. And we are grateful, sir, you have taken out time from your busy schedule to join us today. We have Dr. M.J. Paul, sir. I think sir is in the middle of some important task, so he will be joining us. But not importantly, he is also my mentor. I worked under him during my external posting at CMC Vellore, and I always learned from Paul sir. He was the former head department of endocrine surgery. These are all the international figures, international faculties that I am quoting. And he was the former president of Indian Association of Endocrine Surgeons. So then we have Dr. Pooja Ramakant ma'am. Thank you, ma'am, for joining. It's always a delight to see you. She was my senior. She is still my senior, and I always seek guidance from her. And very robust surgeon, and she is a senior faculty at Department of Breast and Endocrine Surgery at King George's Medical University, Lucknow. And currently, she is the secretary of Indian Association of Endocrine Surgeons. We have Dr. Kripa Alice Cherian, who is a senior faculty at Department of Endocrinology and Metabolism at CMC Vellore. Thank you very much, Dr. Kripa, for joining. I know physicians are too busy, but it's always, it is our luck that like we are among so many physicians tonight. We have Dr. Shivendu Bhardwaj, who is an alumni from Department of Endocrinology at SGPJMS Lucknow. Currently, he is a senior endocrinologist, practicing endocrinologist at Meerut. Dr. Shivendu, are you here with us? Okay, so he'll be joining us shortly. Our team is coordinating him. And we have Dr. Chani Jain. Dr. Chani is a regular figure in this forum, and we work as a team where she helps me in solving the riddles of breast and endocrine pathologies, and because of which she is one of the guiding force, because of which like I'm able to conduct such type of meetings, right? So thank you everyone once again. So now, without wasting much time, now I'm sharing my screen. I hope my audio is proper and it's audible, it's not breaking.
Your audio is quite clear.
Thank you very much, sir.
Screen is also visible now.
Thank you for your feedback, sir. I hope I'm able to convey few of the points which I am going to tell today. So why we have chosen this case, this topic is because it is not something like it is extempore. For past many years, this was in my mind that we should discuss about primary hyperparathyroidism, especially with the physicians of Western UP and the Uttarakhand, which the areas which are drained by my department, right? The reason being, this is my faculty. The reason being, there are lot many things that really I want to convey, which I was not able to until unless I had this forum Brendos. In this forum, we have a very strategic planning of discussing. First, we will be discussing the cases. Then a very, very brief introduction about primary hyperparathyroidism, because I believe most of the attendees are physicians or the endocrine surgeons or the people who have a basic idea about PHPT. Then we will discuss why we are here, why we are discussing these cases, what is the main purpose behind. And then we will have an open discussion with the experts where we will request their comments upon the whole presentation. So everyone, please be there. Don't go anywhere. In case you leave the meeting because of any reason, just join us as soon as possible with the same link. Primary hyperparathyroidism is the symptoms of primary hyperparathyroidism are very, very vast. It's a whole spectrum of symptoms. It is not only one type of symptom, it is a whole spectrum of symptoms. And out of those spectrum, we have chosen 5 representative cases. So we will go through these cases one by one. And as a disclaimer, I would tell we will not go into the detail of how we investigated and everything. We'll just go through their brief history. So the first case was of a 50-year-old male who presented to our department when he was in emergency in a very moribund condition. When we took the history, that was in 2022, he told that he had recurrent nephrolithiasis since 2009 and had a metabolic bone disease since because he had a pathological fracture in his right foot with generalized body pain for few months. Since he had multiple nephrolithiasis, he had multiple nephrolithotomies, and in one such surgery, he developed pyelonephritis, following which he developed chronic kidney disease. And he started on dialysis. When we first met him, he was on dialysis twice weekly. On examination, he had bilateral multinodular goiter with restricted mobility. That time, his calcium was 14.9 and creatinine 6.3. So we after thorough investigation, we localized the lesion and we did the total thyroidectomy, and the parathyroid was also removed. This was the perioperative picture. After surgery, immediately after surgery, his muscle mass, his general condition, his appetite all improved. His post-operative calcium remained in the range of 7 to 8 milligram per deciliter and PTH 200 to 300, which was fairly normal. And his twice weekly dialysis then improved to twice monthly dialysis. But since he was already, his kidney functions were already compromised, he ultimately died after living a healthy life for 2 years. In 2025, he died because of renal failure related complications. Now, we are still not sure, after so many years, we are still not sure whether that was a primary hyperparathyroidism leading to CRF, chronic renal failure, or that was a chronic renal failure leading to tertiary hyperparathyroidism. We are still not clear about this case. Now, coming to the second case. So first, I would like to show you this video. So this is a young lady who is walking. Just appreciate the smile on her face. And you know why this smile was there? Because she remained bedridden for 6 to 7 months. She remained bedridden for 6 to 7 months, or maybe a year, because her bones were so fragile that even while she was taking a turn, one of her bones used to get fracture. Therefore, she stopped walking anymore. Every time she visited a orthopedic surgeon, some nailing or some plating was done. So when she presented to us, you can see this was the cortical bone mineral density, and it was severely osteoporotic. We investigated the case, we localized the lesion, and we removed it. And the result you have already seen. This patient is absolutely normal now, leading a normal life. That was a life-transforming surgery that was being done. Now the third case, who presented to us during COVID era. She was 38-year-old female with recurrent acute pancreatitis. First time in March 2019, second in March 2020, third in April 2021. Then ultimately in May 2021, for the first time, his raised serum calcium was appreciated by the physicians. So when she came to us, we elaborated and found that she had bilateral nephrolithiasis since 2015, and she presented to us in 2021. So for 6 years, she remained undiagnosed. She had a generalized body weakness, and she was also bedridden for 6 to 7 months. She had respiratory infections, urinary infections, bad sores, muscle wasting, and she was the lady. Now just listen to her. आज अच्छे से एक्सरसाइज करनी, ले लो हाथ में पकड़ से नहीं कर पाऊंगी, ठीक है? आज खूब अच्छी एक्सरसाइज करते हैं, जब तक क्यों पैर उठाओ, जरा कोशिश करो, पैर उठाओ, बहुत अकड़ रहे हैं। Just appreciate the muscle wasting that she has. अपने आप से उठ के बैठ सकती है, अपने आप से उठ के नहीं बैठ पाओगी, करवट ले लो कि साइड बाय साइड देके दिखाओ। We investigated, then she was referred to us. We investigated, we operated, right inferior parathyroid gland was enlarged, that was adenoma. We operated, and this is the 1 year post-operative, this is the 2nd year post-operative picture of the same patient. Please appreciate the changes the remarkable changes, the life transforming changes that this patient had after surgery. Now come to our fourth case. This patient was not bedridden. She was not in ICU. She was the normal ambulatory patient that we usually see in our day-to-day practice in our OPDs. She was a 30-year-old female with complaint of low backache for 10 months. She had generalized body pain, body weakness, like the common complaints that we usually see in our patients. She had chronic urinary infection, which we usually attribute to pelvic inflammatory disease. She had hypertension for 8 years. She was 30 years at the time of presentation. She had hypertension for 8 years. Since at the age of 22, she was having hypertension. And the provisional diagnosis that she had was metabolic bone disease with chronic UTI. Luckily, in one of our investigations, after 10 to 12 months of repeated consultations with the physicians, her calcium was identified as raised. That was 15.45. 15.45 is a very high calcium, but it remained unrecognized for 10 to 12 months. So there, her metabolic bone investigations, metabolic bony disease was evaluated, and she was severely osteoporotic. She was a ambulatory patient, but she had severe osteoporosis. These patients are prone for getting bedridden after some time if still ignored. And you can see the expansile osteolytic lesions, very prone for fragile fractures. So luckily, she was diagnosed when she was ambulatory. We investigated, we operated, and the patient was cured of the illness. Now she is absolutely okay, no complaints. And this is the fifth case, the asymptomatic one. The absolutely asymptomatic one with very, very minimal complaints. But luckily, because the physician was aware of doing some calcium screening, and that was recognized on time, which was 13.6. You can notice the upper normal limit of this lab was 10.6. She had 13.6. This patient didn't have any complaints, but her calcium was raised. But after recognizing this hypercalcemia, when she was investigated for bone diseases, for bone disorders, and for renal disorders, so she was osteopenic. She was also severely osteoporotic. This patient was also operated. We confirmed the diagnosis, we localized the lesion, we operated, and this patient is absolutely okay now. She is doing well. Stories are endless. We have so many stories with us. But before we come to our main point, why we are here, a very, very brief about the primary hyperparathyroidism, which we think it's rare, but it is the third most common endocrine disorders in India, in world. We think it is rare, but is it actually rare? We'll just talk about it. And as such, it is the third most common endocrine disorder. Traditionally, we think stones, bones, abdominal growth, psychic modes, the traditional teaching that we have from our textbook is in the developing countries only. Otherwise, in developed countries, now they have an awareness about routine biochemical calcium screening. They more and more incidentally detected asymptomatic hypercalcemia are there. Only in developing countries, we have this problem of stones, bones, abdominal growth, psychic modes. So how do we diagnose? Diagnosis is purely biochemical. We see there is hypercalcemia with elevated or inappropriately normal PTH. If calcium is raised, we expect the PTH to come down. But if it is still raised, that also label the person may be having PHPT. And we also rule out 25-hydroxy vitamin D because it is very common to have vitamin D deficiency in India. So absolutely, it should be within normal range. Then after confirming the diagnosis, we localize the lesion. So there are 4 parathyroid. In other cases, there could be more than 4. Sometimes it is less than 4. But most of the time it is 4, and we localize which particular gland is at offense, and we just go and operate. Because surgery is the definitive treatment. And we will discuss about why I am telling all these things to you. If we remove the overactive gland, cure rate is more than 95%. So in symptomatic patients, we don't have any problem. Okay, patient has kidney stone, bone disease, hypercalcemia, neuropsychiatric symptom, pancreatitis. These are all obvious disease. And we know that in these patients, so we have to operate. Problem comes when the patient is asymptomatic. Patient doesn't have that much clinical problem. Patient is ambulatory in front of us like any other patient, but that patient's biochemical report is suggestive of hypercalcemia. Then comes the main dilemma among the physicians or any other clinician. Here, there are certain guidelines, and we will be discussing because we have experts. Dr. Kripa is there, our IAES faculties is there, endocrine surgery faculties are there. So important, if calcium is more than 1 milligram deciliter above the normal limit of that reference range, or there is severe osteoporosis or fragility fractures, or creatine clearance is low, if there are kidney issues, urinary calcium is more than 400, or age is less than 50 years, then these are the definitive indication. Even if the patient is asymptomatic, we should operate. And why I'm emphasizing on surgery, I will tell you when we will be discussing the statistics. So the question comes, we know diabetes is number 1, thyroid is number 2. Hyperparathyroid, we label it is very low. Yeah, it is very rare. But really, is it very rare? Or because of lack of awareness, we are not doing screening. Now comes the main subject, which I really want to share with you. We are keeping data of all the patients that present to our department. And since 2012, since the time we have started our clinical practice in Meerut, we are keeping data of each and every patient. And today is the time to present and share my agony with each one of you. So since 2012 to 2025, total 60 cases our department have managed. Out of these 60 cases, we have operated 50 cases. 35 were female, 15 were male. Now you please have a look on this chart. Majority of the patients, they had the muscle pain and weakness, neuropsychiatric symptoms, and the bony pains. These were the most important 3 important symptoms which these patients had, which we often neglect. Female है तो इसको neuropsychiatric symptoms होगा. These patients are like this. Majority are females. And they present with muscle pain, weakness, and we say कि इसको vitamin D deficiency हो गई है, ये हो गया, and some, या फिर अगर बिल्कुल समझ में नहीं आता, it's a neuropsychiatric symptom, which is also very common in female. In those 50 cases, we had ectopic glands as well, intrathyroidal, mediastinal, intracarotid, thymic tumors, and we had a cure rate of approximately 100%. Only in 2 cases we had temporary hoarseness, and recently with all our efforts we have started intraoperative PTH and intraoperative frozen section analysis in all our patients. This facility is now available, but this presentation is not about this statistic, this particular slide. This is just for information. The main agony starts from here. So out of those 50 cases, those 60 cases that we have managed or we have seen, majority were a good proportion, 37%, and plus this one, only 56%, half of the patients were ambulatory, remaining patients were bedridden or in ICU. Almost half. And as I've told, we have a drainage from whole Western UP and the Uttarakhand. So this applies to both the areas. During that duration of their problem was ranged from 10 months to 18 years with a mean of 3 to 4 years. Like from the onset of symptoms till their first interaction with the endocrine surgeon, it took 10 months to 18 years with a mean of 3 to 4 years. During that period, they had multiple interaction with various physicians, surgeons, urologists, orthopedic surgeons, gastrosurgeons, and everyone missed the diagnosis. By chance, somehow, because of some aware physician or clinician, their calcium was missed because the symptoms were not resolving. Somehow they got in contact with someone who was aware of calcium. They took the high calcium level seriously, and they referred the patient to us. This slide is much more agonizing and sad. Out of those 60 cases, 8 died. 22, a 22-year-old female died because of acute pancreatitis. By the time they could make up their mind for surgery, the patient died. 22-year-old female. Majority patient died because of renal failure or dialysis-related complications. Few died because of prolonged bedridden, UTI, pneumonia. One patient died because of malignant uncontrolled hypercalcemia. She had surgery, though it was very late, she had surgery, but she had recurrence. Most probably she might be having some parathyroid malignancy. The mortality rate that we are seeing is in the tune of 13.33%. Is it acceptable? We need to understand this. In a benign, non-cancerous lesion, a benign endocrine disorder, we have a mortality of 13.33%. And this is not assumption. These are hard data that I am presenting today. These are facts. These are the actual patients. I'm presenting those with the name because I remember these patients. These pretty faces, I still remember. I was not able to save them because they came very late to me. So I was just thinking, is it really my perception, my department's perception, that we are not getting adequate referrals? The awareness among the clinicians is low? Or is it something else? The fact is something different, and this is only my presumption. So before this meeting, I circulated this pre-meet survey. We got 32 responses. And I request all my faculties to please see all these data, because we will be going to discuss and we really want your opinion regarding each and every point, and especially Dr. Kripa. So out of these 32 responses, majority were physicians and general practitioners. They had more than 20 years of practice. When we asked them, how often do you check serum calcium in routine OPD patients? Majority said only 21% is always. Otherwise, majority sometimes, never, only if indicated rarely. Very few do the calcium screening. Otherwise, majority, they are not doing calcium screening. So when we asked how in last 1 year, how many cases of hyperparathyroidism have you diagnosed? Majority was either no or maximum 1 to 2. Maximum 1 to 2. In which situation do you check calcium? Majority responded when the patient had features of metabolic bone disease, only then. Psychiatric symptoms I have presented. Majority patient had neuropsychiatric symptoms, muscle, bone pains, muscle pain. Those were not very significant in the list of the physicians and the general practitioners. Only when they had a bone pain, osteoporosis, or vitamin D deficiency, then sometimes they check. And I'm extremely sorry because I'm very straightforward in putting my, and I already requested, please take it in a mature note. There is nothing personal in this presentation. It's only the hard fact that I'm presenting for the benefit of the society and the patients. Do you check calcium and inorganic phosphorus before prescribing vitamin D? Sometimes, by majority. Very few says always. So do you think a patient with fragility fracture, it's always because of vitamin D deficiency? Do you think, should we think like this? 15.6% rarely, never. So this is the hard reality of our medical society right now. So what is the threshold for ignoring elevated calcium? depends on the system by 31.3%. Depends on the symptoms. So if the patient is asymptomatic, do you think that we should ignore the elevated calcium? 31.3 means 1/3. Majority, a quite number up to 11 they ignore. But like this is bit surprising. Depend upon the system. So suppose the patient is asymptomatic, should we still ignore the elevated serum calcium? This is my point. So when should we order PTH? Approximately 50%, rarely, frequently, never. Approximately 50%. Never also. 12.5% say they never order PTH. So we asked why. Which prevents you from ordering PTH more often. So, not a part of routine practice. Because maybe they were never, in none of their forums, it was discussed. It could be the problem. In none of their forum, it was discussed, considering it is a very rare disease. It was never discussed. And now I am raising my point. Is it really a rare disease, or because of lack of screening, we are missing the cases? Some say it cost, others lack of suspicion, unclear indications. I sees what the mind knows. So it's very important to regularly train our minds of what is going on, what is there in the, what is coming up next. So at what stage would you consider surgical referral in suspected PHPT? This is something very, very surprising to me. Approximately 50% say only if symptomatic. Even if the calcium is elevated, if the patient is not symptomatic, they don't consider it for surgical evaluation. Only if severe. This one, yellow. So we are waiting for the severity to increase. And you are seeing all the results there. Prefer medical management first, 28%. Approximately 1/3 of the physicians say they prefer medical management first. So through this forum, and now we have experts with us, would like to understand primary hyperparathyroidism, is it a medical disease or it is a surgical disease? We'll talk about the cost also, cost of medical management versus cost of surgical management in such patients. Now, this is a very interesting slide, and I request all the faculties and all the participants to please have a thorough look on this slide. Because in this slide, in this question, we try to bring out their apprehension for the surgery. So if you rarely refer for surgery in PHPT, what are your concerns? What are your concerns? According to the physicians, majority said 28%, patient was reluctant. Is it so? Can patient decide the treatment which we physicians also don't know about? We clinicians don't have much information about. It is our responsibility. It should be our responsibility to inform them with robust information. Then others, someone said like uncertainty about indications, 9.4%, uncertainty about outcomes. So I request all the surgeons, all the endocrine surgeons to, when we'll be discussing about this thing. So since we have a majority of physicians in this forum today, we can discuss about bilaterally, is the outcome really so bad after surgery? So we are hesitant in referring for the surgical management. Now 9.4% say prefer for medical management. That is why they don't refer a PHPT for surgery. Limited access to specialized surgeon. Now we have so many endocrine surgeons with us. So anyone who has marked this answer can have a thorough discussion regarding the availability. Now, this is the last slide. Have you ever followed up a patient after surgery for hyperparathyroidism? Majority said no. No. So those who manage hyperparathyroidism, they haven't seen the response with the surgery, majority. And maybe do you think hyperparathyroidism, but they admit that it is underdiagnosed in routine practice, it is underdiagnosed. So here comes our responsibility as a specialist, both as endocrine surgeon and endocrinologist, to through various means we should sensitize our medical fraternity about this problem, which is there in our society but often missed or overlooked because of lack of awareness. And with this I now conclude my slides, and your opinion really matters a lot to us. And with this I open this forum for discussion. I'm stopping my screen share so that we all can see each other. So is it my screen is, I think my screen share has stopped. No, no, it's all already visible. Stop sharing. Stop sharing. Yes, stop. I'm sorry. Yeah, okay. Thank you. Fine. I hope with this presentation I have made some points to all our participants. So I now open this forum for discussion. And first, I would like to have opinions from our API Meerut and the API Meerut faculties. We have Sandeep sir with us. We have HM Rastogi sir with us. Abha ma'am, have you? Yeah. So Harish Mohan sir, can you please say some words regarding?
Dr. Sudhi, it was an excellent presentation and an eye-opener. It insists us to be more serious about the diagnosis of hyperparathyroidism, for which we are not usually serious. Therefore, if patient present with symptoms, as you have already mentioned, and we found that patient is having hypercalcemia, we must investigate for hyperparathyroidism.
Thank you, sir. Sandeep sir, would you like to? Then we will be having discussions with other people. Dr. Kripa, I would like to keep you at the end after taking comments from other, because I request Dr. Kripa, just you have been through all sides. I can share my screen again to show everything. And point wise, if you can tell as a physician, as an endocrine physician, about each and every questions that I have asked, and you
So,
can just elaborate those things, so that would be helpful for the other colleagues.
so Dr.
Yes, sir,
Sudhi,
Sandeep sir.
Dr. Sudhi, first of all, I would like to congratulate you for the nice presentation, nice content, and definitely to conduct the survey. And when I myself was going through the survey, I could feel that these points are very valid. And what I initially told you, that it's the responsibility of the clinicians to actually be aware of this. And once the clinicians are aware, because first and foremost we are going to attend the patients, and then only we can give a better treatment and we can advise. And I think the most important part was that just how to ignore a patient with high calcium is a very important issue. And the varied symptoms which you have, and definitely when I was going through the data and all the literature, apart from the bony pain, all the psychiatric symptoms which the patient has, persistent having renal calculi and all these things, and very high calcium, apart from vitamin D being used still not that low. So the mind should go for that. And the important thing is that we clinicians in ourselves are not so much sure that what should be the proper treatment, and but we know those who are aware that the surgical treatment is the only gold standard treatment, which will have no relapses and the patient will recover very nicely if properly done. But the thing is, sometimes the diagnosis is late, and on the other times when even diagnosed, and we as a physician we advise all the things, the patients definitely, once we advise surgery, they go away. And the physicians, the purpose and the duty of the physician is to tell all the pros and cons, and also tell that the surgical treatment is the gold standard treatment. Other medicines will just help you dialysis and in the later state. These are just to give you some comfort. But as far as the treatment is concerned, the surgery is the only answer. But sometimes too, I have talked to other physicians also. The patient constraint, they go away. Just you and you advise the surgery, they will go away. They will never turn up to you, even if you tell them to go and see. So this is a real practical problem which we see. But as a physicians and clinicians, we should have our duty to know what is correct and we should advise what is correct. So this is my submission.
Thank you very much, sir. And now, because before I move on to surgeons, may I request Dr. Kripa, you have been through the presentation. Now, can you please give, because you are a physician, you are a midway between the general physician and the endo. You have an interaction with both. So, can you now tell what is the exact management? We are discussing about the management, how it should be there, uh, about these slides and all these questions. Then I'll
Yeah,
move on
thank
to
you.
surgeons.
Thank you very much, Dr. Sudhi, and that was an excellent presentation. All the five cases that you presented. Firstly, it is unfortunate that the diagnosis came in late. So, to all my physician colleagues and the others participants who are watching, firstly, the first case that was presented was one of recurrent nephrolithiasis. So, any patient presenting as a stone for former warrants evaluation. And the minimal tests that can be done in this scenario are an albumin corrected calcium and a uric acid. So, that will rule out one of the most common etiologies for nephrolithiasis. And recurrent stone formers, of course, they need additional 24-hour urine tests that can be done later. With regards to the second patient that was presented with recurrent fractures, once again, when there are recurrent fragility fractures, the rule of thumb is that it is always a case of secondary osteoporosis unless it is proved otherwise. And any case of secondary osteoporosis, once again, PHPT, we discussed that it is amongst the most common of endocrine conditions. PHPT definitely needs to be ruled out. The third presentation was pancreatitis, and we see a lot of pancreatitis, PHPT presenting as pancreatitis in this part of the world. Many of our Western colleagues don't agree with this fact because I'm not sure if these are ethnicity-based differences, but particularly in the US, they don't agree that PHPT actually presents with pancreatitis because for them that is very rare. So any patient who presents with a pancreatitis, if the obvious causes are ruled out, for example, gallstones and chronic alcoholism, if the pancreatitis is idiopathic, definitely it needs exclusion of other metabolic abnormalities like hypertriglyceridemia and hypercalcemia related to PHPT. Another caveat that should be kept in mind is that in the face of acute pancreatitis, if the calcium levels are normal, that does not exclude PHPT. The reason is that in the face of acute pancreatitis, there can be saponification and the calcium levels can actually be low. So do one more set of calcium once the patient has recovered from the acute pancreatitis. So that's one point that I would like to make over here. Not only that, in the context of PHPT, we've had a couple of patients who actually had a PHPT related to a familial hypocalciuric hypercalcemia. So it's not enough that you do just the calcium and the PTH in such cases. The workup needs to be completed with the 24-hour urine collections as well. And we were discussing treatment, and you had shown the results of your survey. So there is no doubt that the definitive management of primary hyperparathyroidism is surgery, unless the patient has multi-morbidity and is extremely elderly that surgery is contraindicated. In the absence of such contraindication, surgery is definitely the management. Of course, there is cinacalcet, there are bone protection agents, but these do not protect against the cardiovascular risk associated with PHPT. And cinacalcet does not protect the bone either. So no doubt the management is definitely surgical.
Okay, thank you very much, Dr. Kripa. And I'll come to you further after I have comments from our IAES faculties, endocrine surgery faculties. So I would like to request Gaurav sir. So, sir, you have been through all this presentation, and I know like our department also evolved while raising awareness among the physicians, and luckily we have endocrinology department with us. But your comments are really valuable.
Yeah. So the nice presentation. Uh, it is sad that we continue to see patients with such neglected and advanced, complicated symptomatic hyperparathyroidism. And I feel the only, um, I mean, the only way to describe these cases is neglected. These are, and nothing what you presented today was surprising to me. I mean, all of us who have been treating primary hyperparathyroidism, or for that matter, any metabolic bone diseases and hyperparathyroidism, uh, we have been seeing such patients. We feel sad that these patients have remained untreated for long and have suffered for so long. But while I share your agony and disappointment, I would like to tell you there's light at the end of this tunnel. I mean, I I'm sure all endocrine surgeons who've been treating hyperparathyroidism for some years will agree with this statement. Compared to, say, 3 decades ago, the kind of patients we treat today, the numbers are greater, and there are quite a few who are either asymptomatic or minimally symptomatic and certainly do not have any fragility fractures or renal failure or any such life-threatening or such conditions which are threatening their quality of life. So compared to 3 decades ago, when almost every patient we treated, almost every other patient was bedridden, and you are aware that we have published the kind of phenotype of the disease that we unfortunately were seeing at that time. We described the terms like parathyroid cripple and syndrome of disappearing bone in patients who had extreme osteopenia, and even long bones were not visible on routine X-ray. Fortunately, those kind of severely symptomatic patients are far and few today, and a larger proportion have relatively earlier stage disease. So that is a proof enough for me that there is improving awareness about hyperparathyroidism, and uh, uh, to some extent, at least in the larger cities today, quite a few hospitals and doctors they are undertaking biochemical screening for hypercalcemia too. Uh, Now, what is the way forward? The way forward is exactly what you are trying to do. Bring together physicians and surgeons and try to create awareness about hyperparathyroidism. I'm sure you know that the American Association of Endocrine Surgeons and a few other organizations observe July as the Parathyroid Awareness Month. There is no reason why we should also not continue to make some efforts. Indian Association of Endocrine Surgeons certainly has plans to do a few activities in this line. Uh, Second part of my comment would be, I mean, maybe you can say old habits die hard. We all uh, practice medicine or surgery the way we have seen our teachers and their generation and their peers practicing medicine or surgery. Unfortunately, even today, there seems to be, of course, all the points that you made, all the reasons why surgical referrals are not done are certainly, many of them are very valid reasons, but a substantial proportion of patients continue to be to be devoid of surgical treatment, or they do not get surgical treatment primarily because the treating doctors, it may be physician, it may be a nephrologist or urologist or an orthopedic surgeon or a gynecologist or a psychiatrist or whosoever, and many surgeons are not aware about the facts that primary hyperparathyroidism is an eminently curable and treatable disease with, as you showed, life transforming stories after cure of hyperparathyroidism. There are so many cripples who walk. There are so many patients with pathetic quality of life who improve. They lead a meaningful and healthy life after surgical cure. So the awareness is needed not within a certain specialist society or physicians. The awareness is needed for every possible doctor who practices in India, right from primary care and rather more for the primary care physicians, so that timely diagnosis, and if diagnosis is made, then appropriate referral for surgical cure is done. Third point, sorry, I'm taking a little long, but
No,
the
sir,
third
this is the core of.
the
Yes.
third point I would like to make is that at least today, hyperparathyroidism surgery is a specialist surgery, is specialized surgery to be done by surgeons trained and experienced in parathyroid surgery, because the first time is the best time to cure a patient, and unless the surgeon has a training and experience in treating these patients, one can do harm, more harm than good to the patients. There are a number of studies which tell us that specialized parathyroid surgeons, they can achieve cure rates exceeding 95%, even in patients where you do not have preoperative localization based on imaging, compared to non-specialized surgeons where the cure rates drop to about 80%. So 1 in 5 patient remains uncured. And the morbidity of surgery itself can be much higher in hands of surgeons who are anecdotal. Only once in a blue moon they would be doing parathyroid surgery. And this is counterproductive because every botched up, every bad result disheartens the physicians and everybody who's a stakeholder in this whole story from referring patients for parathyroidectomy. So the awareness is needed not only for diagnosis but also for uh, uh, identifying the right people to treat these patients. Um, Physicians, surgeons, diagnosticians, including imaging and pathologists, all of these who are capable of diagnosing and treating hyperparathyroidism patients, it is absolutely essential to create such a awareness. And I laud your efforts. We must continue to do the same on a wider scale. Thank you very much.
Thank you very much, sir. And your feedback was very important. Now we have MJ Paul, sir. MJ Paul, sir, is, as already told, he is the former HOD Department of Endocrine Surgery at CMC Vellore. CMC Vellore is a very, very high volume endocrine surgery center, catering quite a bigger area. And thank you, sir, for being with us tonight. One of the questions that we raised, if you rarely refer for surgery in PHPT, what are your concerns? So among the various concerns was uncertainty about indications, uncertainty about outcomes, patient reluctance. These were the major problems that the clinicians they showed us. One was limited access to the specialized surgeons. So would you like to comment on all these?
Yeah, thank you, Sudhi. And it was very interesting. And parathyroid remains a very hot topic in our setup because of the delayed presentation. I'll just make a few points. I'm sorry, I may lose my connectivity. So, as you set out the message in the medical groups from surgeons and from the specialty endocrinologists, that the pickup has to be earlier. That's number one. Second is the patient reluctance to surgery. So we have to put it out that it is safe and in the right hands, it's very effective. And as you said, the dramatic stories where the lives are turned around are really motivation for people to come forward for surgery. And that we have a different profile. As we know, 90% is symptomatic in most of the Indian scenario, and we see still only a very minority of cases who are asymptomatic on screening. But right now we need to focus on the symptomatic ones that are getting missed. I think that message has to go out strongly from both physicians and surgeons. Regarding the other end of the spectrum, we are obviously going to see more and more of the asymptomatic ones come. So I would personally have a little more uh, conservative approach when you say you have a 70-year-old who has very much.
So, Pooja ma'am, I would like to ask you one question that we raised: whom do you consider referring the patient to for surgery? So, there's a quite a good number of respondents. They said like ENT surgeons, general surgeons. Majority said endocrine surgeons. But here comes one very important thing that I mentioned, was more than 95% cure in the hands of experts. Who are these experts? Who should operate these patients, and why they are different from other surgeons?
Yeah, Dr. Sudhi, that's a very relevant and valid point you have raised. Actually, parathyroid is a gland where even we who are being trained to do it, we still find it difficult at times. And I have seen even as people, we take help and we guidance from seniors also. Sometimes we get stuck, we don't find the lesion or we miss the lesion. That has happened, I think, to every endocrine surgeon some point in their life. And we keep learning from each other's problems, what they faced, why it was missed, why, and then picking up the persistent or the recurrent PHPTs. So if we give in the hands of people who don't have that knowledge of persistence, recurrence, supernumerary glands, missed glands, who are doing once in a year or so, other specialties who are not regularly managing endocrine patients, it becomes more difficult and higher chance of failure in that hands. And that depresses the patients and they further get motivated for the second surgery. And we all know second surgery or third surgery becomes much more difficult. The complication rates are much higher in other surgeries than the first one. And 80% times a missed gland is in the normal location, not in abnormal location. It was just because the surgeon didn't have the knowledge of the anatomical planes and may have missed it. So then we do 4D CT and other functional images, which are much more costly, and it hampers the patient's life. I've seen patient being in the ward for more than a month just because of waiting for second surgery or for localizing imaging to be happening. So I think the first surgery is the best surgery, and that should happen by an endocrine surgeon. There's no doubt about it. The results will be much better compared to others. Regarding the awareness part, I think the orthopedic surgeons and the urologists also need to be more aware because they see many a times patients having renal stone and they may would not have checked the calcium, or a person gets a fracture and goes and the calcium was not checked. And then when recurrent episodes happen and then we check, by that time I think it gets very late. So I think that level also we need to target people.
Yes, definitely. For those who have the doubt whether even if they diagnose primary hyperparathyroidism and they know that this is a surgical problem and I have to refer these patients, then the question comes to whom. So in one of my slides, I showed there were ectopic glands. Parathyroid has a tendency for ectopic location because, as we know, it arises from the third and the fourth branchial arches. In out of 50 cases, we had around 5 cases with ectopic parathyroid tissue, ectopic parathyroid location. That is around 10%. So we know that these are very tricky glands. These are not just like you go and operate. We have to see all the other. We have to assess. We really need to check whether the whether the excision is complete or not. So these are those who are especially trained in this surgical technique, only they can give their 100%. Otherwise, because as we know, patients are reluctant, that we have seen in our slides. And if we fail if the surgery is failed, this reluctance will increase further. a common science level. So it is always important. Now we have endocrine surgeons throughout the country, where we can, according to where you have the accessibility, so we can, where you can very well refer your patients to endocrine surgeons. So we have Arvindan Nair sir, and I cannot miss the opportunity to get the expert comments from Arvindan sir. He's like a father figure for all of us. Thank you very much, sir, for joining. So you have seen the whole presentation. Physicians are with us. So would you like to comment on this presentation, and also something which we can share with our physician colleagues, so that together we can make some difference in the society?
Thank you, Sudhi, for your nice presentation. If you look at the spectrum, so I have been in this field for the past 40 years, and what we saw when we began is what you have presented today. But we continue to see some patients, not the large. One thing is, in CMC is a large referral center, so we get many patients who are referred directly. But the other thing is that the awareness is still lacking, despite all the advances in diagnosis and imaging. So one thing is, as you have very rightly, everyone has rightly pointed, the question of awareness and surgery. And one of the things that physicians have is that many conditions, not only for us, any specialty, physicians always feel that they should first have a go at treatment of the patient. And because when nowadays, because with this multi-channel analyzer, calcium is diagnosed routinely. So the question is always, because I am telling this because yesterday we had our department, we presented our parathyroid disorders, and we had physicians, and the first thing physician got up, a senior most physician in Vellore. I don't think all patients with hyperparathyroidism need surgery. 80% can be managed medically. So that is the attitude of many physicians who feel that they should treat them till they become really symptomatic. But if you go into the history of every parathyroid patient, right from the word go, they have minimal symptoms, subtle symptoms, like they feel they are not very active, they feel they are sleepy, or they feel they can't concentrate well, which is often neglected. So asymptomatic is not really a true sense asymptomatic. They have minor subtle symptoms which are often missed. But if you go into the history, because we see some patients directly, and the moment we ask them, and we know this patient has possibly a hyperparathyroidism. But because we are endocrine surgeons, we look for it specifically. But that is what we have to create, that although they are asymptomatic, they are not truly asymptomatic. They have subtle symptoms which patients tend to ignore, or which we as doctors tend to ignore. That is very important point in diagnosing these patients. And of course, imaging has made a large difference, especially with the arrival of PET scan. That is one condition that has made referrals much more than before, because every patient who has anything, they'll always do a PET scan, and that picks up a lesion, and then they check calcium, and PTH we find is very high. So
thank you. Yeah.
So that is what is the pattern has changed completely from what we saw 30, 40 years ago, and now we see much less, but we still do see very symptomatic crippling patients also, especially the fractures and the nephrocalcinosis coming with chronic renal failure.
Sir. Thank you, sir. And I could see Dr. Sandeep Kumar Garg, sir, is with us. He's a very prominent nephrologist of Meerut, and a very good academician. I could see, I often see sir is in academic activities, and this nephrologists are the ones which I have seen. They pick a lot of parathyroid patients because they routinely do calcium. Sir, if you are here, I would like to have some comments from you. Or Dr. Maybe sir is busy somewhere, but Dr. Kripa, the two important things I would like to understand from you. First of all, you are a physician. You are an endocrinologist, so you see so many parathyroids. Can you maybe tell what are the various reasons why the other physicians don't have much awareness about calcium, and what can we do to enhance this awareness?
Yeah, so as somebody, Arvindan sir had mentioned that we are a referral center. So many patients who come to us probably have their calciums checked elsewhere. But like you said, why it is not done is I feel because of a lack of awareness. Because just like the patient you showed with the video who was later walking, we had a similar patient with every side that she was turning in bed, she was fracturing. So she had been having very vague symptoms of some bony pains, generalized body aches for almost 5 to 6 years, and nobody had done so much as to check a serum calcium for her. Finally, it is only when she presented with a DVT that she came to us and she was diagnosed to have a primary hyperparathyroidism. So I think, firstly, why it is not checked is I think mostly because of a lack of awareness about this condition. The other thing is that primary hyperparathyroidism is like a great masquerader. It can have so many different kinds of presentations. Like we've had patients who've presented only with deep vein thrombosis. We've had patients who have presented with pancytopenia because of marrow fibrosis. So that patient presented with tiredness, then was found to have pancytopenia, got admitted under hematology who did not do a calcium, but because of marrow fibrosis, they did a bone marrow, and the pathologist told us there is extensive marrow fibrosis. Please check the patient's calcium. So, that is another thing with primary hyperparathyroidism. So different presentations that it can have. But how to improve and increase awareness, I think, is probably we can disseminate such information on social media. Like you said, a parathyroid awareness month is coming up. So probably some programs, webinars, discussions, Facebook live presentations can be conducted to disseminate that knowledge and awareness, I think.
Thank you very much. And though this forum may not be that right, and just think it as a baby step or some small atomic effort, that I extend my hands, I extend my invitation to both the physicians and the endocrinologists. If together we can create some awareness about parathyroid disorders, because
Sure, yes.
one person cannot do any magic. We are a part of society. It is a multidisciplinary problem, clinical problem. So just I extend my small invitation to you all through various forums, through various case discussion. If we talk more and more about this clinical problem, probably we will be contributing more to our clinical profession and to the society, because these 13.3%, these patients may be only 13.3% for us, but for that family, that patient is 100%. That outcome is 100%. And Sandeep sir, is there? Okay, I really want to have some inputs from the nephrologist, but sir might be busy. And one last question from Dr. Kripa, and we are just on time. And one last question we are receiving some requests. We are talking about more and more about calcium screening. So if you can tell what exactly, suppose we have some clinical suspicion of PHPT, or we want to check calcium, even if the patient is asymptomatic, what test should we order so that we can pick as much potential patients as possible? You are mute.
We should do an albumin adjusted calcium, and if it is high, then a PTH. Then the other test would be in case of a primary hyperparathyroidism to look at the renal functions, a 25-hydroxy vitamin D, and to look for the end organ damage, the other tests like the DEXA scan, the ultrasound, the 24-hour urine parameters, uh, followed by localization.
As such, the parathyroid and other investigations are costly, and a majority patients are not able to afford. Screening me, you said calcium, albumin adjusted corrected calcium. Does it mean ionized calcium, or is it something different?
No, I meant the total calcium. The total calcium that is bound to albumin.
So is there any specific test that we can ask a pathologist, or we have to check the albumin, check the total calcium and correct
So
ourselves?
along with the calcium, you would also check an albumin. Because if
Mhm.
the albumin is low, then the actual calcium will be higher.
Okay, so then how do we do this, the albumin corrected calcium? This is for the benefit of all the physicians that are here with us. And in busy
Yeah,
OPD,
I'm sure that we know that we have to correct the calcium for the albumin. So if we correct the albumin to a value of 4. So if the albumin is only 3, for example, so you have to add, you have to correct it to an albumin of 4. So 4 minus 3 is 1, multiplied by 0.8, that is the correction factor, and you add it to the value of calcium that you get to get the actual calcium report. So if the calcium, for example, if the calcium was only say 10 on the measured value and the albumin was 3, then the actual calcium is 10 plus 0.8. 10 plus 4 minus 3 into 0.8. So that is how it is. The albumin adjusted calcium is done.
right,
And of
right.
course, the phosphate should always be measured in a fasting state. And I would also like to emphasize that there is an entity called normocalcemic hyperparathyroidism. So that can be missed if the fasting phosphate is not checked. Because even in a normocalcemic hyperparathyroidism, when done on the fasting state, the calcium levels might be normal, the PTH is high, and the phosphate is low. So these are other surrogate clues that could tell you that it might actually be a parathyroid disease. And of course, other secondary causes for a hyperparathyroidism should be excluded.
Right. So this phosphate, you mean inorganic phosphorus, or this is alkaline phosphatase?
No, so alkaline phosphatase is different. What I mean is the phosphate, the inorganic phosphate that is measured along with calcium.
Inorganic
Al
phosphorus.
phosphate, yeah. It's not
Yeah.
the elemental phosphorus that is measured, it is the inorganic phosphate that is measured.
Okay. So what we need to write is the calcium, albumin, and inorganic phosphate to our lab
Phosphate, yeah.
pathology
Yeah,
colleagues. Right.
yeah,
And if it comes out to be abnormal, then we should proceed with PTH, vitamin D, and other factors. Am I
correct.
right?
Yes, yes.
Yeah. And if that also comes to be like inappropriately raised or raised PTH in the view of hypercalcemia, then comes the requirement for other
Localization and the end organ damage. Yeah.
and organ damage. I
Yeah.
think this is a very straightforward and very clear algorithm that Dr. Kripa has told us. Now I invite questions from the participants. So the physicians are with us. Anyone, any surgeon, physician, whosoever is with us, we have our expert panels. If you have any question in your mind, please go. Don't leave this session without getting the answers. So there's one question. It is sample collection empty stomach that you have already answered? It should be preferably be fasting and without tourniquet and test. So what is the use of this tourniquet? Why we should avoid having the tourniquet for sampling?
Yeah, so that used to be the previous teaching because when you tie a tourniquet, then there is a local hemo concentration that can happen, and the calcium levels can appear to be spuriously high. So that is why the teaching was to draw a calcium sample without using a tourniquet. But actually, if you were to correct for albumin, then that should not be a problem because if there is a hemo concentration, if there's a local hemo concentration, then the measured albumin will also be high. And if you were to correct it, then that problem does not arise.
Right. Thank you. One very quick question. In many patients that I have also seen that we have clinical suspicion of hyperparathyroidism. The calcium is also marginally raised, but PTH, when we send the PTH, intact PTH, it doesn't come up to our expectation. It is low. If we are not sure whether it is furiously low or it is low. So any specific precaution do we ask our collection boy to take care, or is it okay? Like that person can collect in any way?
Yeah, so the PTH sample that is collected should be collected on ice. So that is a pre-analytical yeah, problem. If it is not collected on ice, you can have erroneous values. So if you get values that you think are not appropriately high, then I would suggest that you repeat the sample with proper collection in a plasma tube on ice. We've also had with the new campus of CMC coming up, and these PTH and hormonal assays are done on the main campus. So if it is not being transported appropriately, we've had low values, which when we repeated actually came out to be high. So that is one thing that should be kept in mind.
So
The other
what
entity is if there's a low, if the PTH is not very high, but the calcium is high. Also, a newer entity called a normal hormonal hyperparathyroidism, in which that's also being described.
some audio issues are there? Yeah. So the parathyroid hormone is a very thermal sensitive and time sensitive hormone. The half-life of this hormone is around 2 to 5 minutes. So it's very important that it is immediately transferred into the plasma tube, is transferred into an ice pack or a liquid nitrogen, and immediately transferred to the lab where it is centrifuged and the plasma is separated. I think there is some issue with Dr. Kripa's network. So now we are at the end of our presentation today. And before I close it formally, first of all, I request all our faculties and the participants to please switch on their cameras so that our team can have a selfie with all of us. And thank you very much, sir. And all the participants, I request, I can see their lovely faces if possible. Thank you everyone. Right. And today's session was really very, I could say, fantastic. I was waiting for this session for quite a long time, and today it happened. I hope me and my team was able to deliberate the messages that we wanted to share with our physician colleagues. Quick comments are invited from our faculties and the participants regarding this program and such programs that we usually routinely held, and that would be motivating for our team as well. So Gaurav sir, Paul sir, Pooja ma'am, Chani, Sandeep sir.
Yes, yes, it was really wonderful and very informative, and really put an insight that we should have more and more such programs, and maybe in our forums also. Digitally, it's quite good because we can access many people, but definitely on our forums also. So very soon I'll think upon it, and we'll plan a meeting with you. So we'll have it soon only.
Thank you very much, sir, for taking this initiative, sir. Gaurav sir.
I think I've said this earlier, so it is a good initiative. Continue with it. When it comes to awareness regarding anything, you cannot overdo it. You have to, or rather, any amount of awareness efforts are going to fall short. There is no end to what you can do. So, my good wishes to you. Please continue doing the good job, and hopefully, we will be able to reach out to a large number of physicians, make them aware about these diseases as well.
Thank you very much, sir. Pooja ma'am.
Thank you, Sudhi, for organizing it. It was wonderful. And thank you for doing it under the aegis of IAES. And good to have surgeons and physicians together on board. It's a teamwork, and we all need to contribute and make our contributions and work together. I think that's a fantastic message. Thank you. All the best.
Dr. Kripa.
Yeah, thank you, Dr. Sudhi. It was a really good session, and I think more and more of such sessions are required, particularly where the awareness is suboptimal.
Thank you. Dr. Chani.
And it was a very well collected and displayed data, and we all need a higher index of suspicion. And I just want to point that proper sample collection of PTH is very important. Otherwise, despite having index suspicion and the patient spending, but the results will not get as per expectations.
Thank you, Reshma. We have Richa Jain ma'am with us. Ma'am, would you like to contribute something?
Yeah, I was really inspired by all the things that I've heard today. And as HOD of General Surgery Department at SMS Medical College, I think along with having a breast screening program for women in our OPDs, I'm going to add this parathyroid screening as well. And this is one of the things that women need to be screened about. Although in general surgery, we do get the parathyroid scenario in pancreatitis patients and sometimes in DVT, because the other patients, they generally land up with the orthopedics or urologist or psychiatry uh, or nephrologist. So, but we'll be now on a lookout for this, and this is another way to be a spy in the OPD and in the IPD. Thank you.
Thank you
Love
very
the
much, sir.
entire session and all the involved um, faculty here. Very well versed, and especially the insights with Dr. Cherry. And I would like to have them in written, if possible, to share with in my department academic group, because I have to spread the awareness to my faculty with this and my residents about this.
In my best.
They were really detailed, and an eye for a detail is very important in these things.
Thank you.
Parathyroid is sensitive. Yeah. Thank you.
So, thank you. Vijay Bahadur sir is with us. Sir, would you like to add something? Would you like to say something regarding the program? Okay, so now before I wind it off, is a couple of announcements. Next time, those who practice breast surgeries, there's a very interesting session which is being planned on the last Friday of April. And we are going to discuss about genetics in breast cancer in a very, very simplified form, which is clinically relevant to the clinical practice. So stay tuned. The details will be shared soon. And on 12th of April, at our center in Utima Hospital, we are going to conduct a live operative workshop on scarlet breast lump excision. So those who practice breast surgeries are welcome. The details will be shared shortly. All these meetings are recorded, so this meeting will also be uploaded, and the link will be shared soon in the group. So stay connected with us. And with this, I would like to thank you all once again from the core of my heart for giving your valuable time and giving such valuable insights. And with this, now I formally close this meeting with a promise to meet again in our next meeting. Thank you very much, and have a good night.